I'm back with another study that looks at what happens to patients who have these conventional orthopedic diagnoses when you apply repeated movement testing as part of the orthopedic evaluation and possibly repeated movements into a directional preference as part of the treatment. So today we're talking about people who present with toe and plantar foot symptoms that fit the criteria held in contemporary orthopedics of a Morton's neuroma. The study is called Mechanical Diagnosis and Therapy and Morton's Neuroma, a case series. They focus just on 3 patients. The authors, Michael Post and Joseph Maccio, are both highly trained in using repeated movement testing, which is the McKenzie method or MDT. Michael Post, I think, was the clinician carrying out the clinical care. Published in 2019 in the Journal of Manual and Manipulative Therapy. And again, this focuses on 3 patients who fit the criteria of Morton's neuroma, but that definition can be called into question when they added repeated movement testing to the care of these patients. So as a foreword, they recognize that the clinical guidelines are injections and surgery as first-line approaches for treatment when it comes to a diagnosis of Morton's neuroma. And something I didn't know, which I learned, is that Morton's neuroma is the second most common compressive neuropathy, with carpal tunnel being the first. So yes, nerves can be entrapped in the periphery. That is absolutely true, but we need to call into question if what we see on an image is necessarily something that anatomically needs to be treated, structurally needs to be treated, or maybe there's a physiological way to improve symptoms and signs. And we need to call into question the orthopedic special tests that we all learn that are maybe not as reliable or valid as they say they are. So the primary outcomes of this study: pain, the numerical pain rating scale, a 10-minute walk test, global perceived effect, and the GROC, global rating of change. The clinical tests use the Mulder's click test, the squeeze test, plantar percussion, web space tenderness test, and then range of motion of the toes, the metatarsophalangeal joints, and the lumbar spine, and looking at posture. And just by adding lumbar spine range of motion to the patient's evaluation is something that I would say is quite different than what many patients are getting when they complain of toe and foot symptoms alone. So we, people who use repeated movement testing, almost always include range of motion testing of the spine when it comes to extremity symptoms for the level that's appropriate. So for the foot, that would obviously be the low back. Now, something in the specific verbal history or the baseline testing might not make us go to the lumbar spine with repeated movement testing first, but we're almost always gathering at least some baselines so we know where we're starting from. So there are 3 patients. Patient 1, 75-year-old female, intermittent right plantar foot pain and toe discomfort. Insidious, came on for no apparent reason for 5 weeks. Worse with weight bearing with tight shoes. Ultrasound was positive for a 3.5 millimeter neuroma in the second web space. Also clinical tests that were positive were the squeeze test and palpation test. So again, fitting the criteria that we all seem to agree on is Morton's neuroma. And if you believe the diagnosis is Morton's neuroma, you're likely to look at injections or surgery. There's some research that looks at physical therapy interventions or other interventions that are not as invasive, but there's not a lot out there. So this is why studies like this are needed, to try to hone in on management for these patients. But first you gotta get the diagnosis right. So when they took her baselines for the second, we'll just call it the second toe, flexion had a moderate loss with end range pain. Extension of the toe had moderate loss without pain. When the clinician looked at lumbar range of motion, there was a minimal loss of lumbar extension. Other planes of lumbar range of motion were normal. Now, again, if you're not using MDT, McKenzie method repeated movement testing, the exam could include other things, but it wouldn't continue on to repeated movement testing. So repeated movement testing as part of the orthopedic evaluation, even if you do all the other mainstream stuff, it's an addition, really sets it apart from the mainstream orthopedic evaluation. So repeated movement testing, they moved the lumbar spine and found no effect on the baselines, which included the range of motion, I think heel raise on both feet. They use different baselines for different people, such as walking or the heel raise, but there was no effect. So repeated movement testing is move the joint in a specific direction repeatedly and retest the effect on the baselines. So they found no effect with lumbar. They moved on to semi-loaded toe extension repeatedly, found that symptoms and signs, or at least signs, were better in the clinic, and therefore that became the home program to continue to test semi-loaded toe extension over the course of several days and assess the effect on the patient's perceived symptoms at home. For example, is weight bearing with tight shoes any better or not? On visit number 2, they retested what they had been doing despite improvement to see if they needed more and more of that. They found that they needed to add more force. So they went to loaded toe extension repeatedly and sent the patient home with that because they saw an effect, a positive effect, by adding more force into full loading versus semi-loading. The patient returned on visit 3 and was satisfied with her improvement and was discharged. So they followed up by phone at 6 months and 12 months, which I really like, and the patient reported no problems. So when we asked the diagnosis, could there be or is there a neuroma on imaging? Yes. Is it the patient's problem that cannot be fixed with movement? No. So we can have this debate over what is actually causing the pain, and that's a valid debate. But the signs and symptoms were abolished by moving repeatedly into repeated toe extension. So for our terminology, the diagnosis, because it responded to repeated movement in a specific direction, is joint derangement. So joint derangement is the diagnosis with a directional preference of toe extension in loaded. We should have these debates over what exactly is happening when we do that, but at the end of the day, it can be addressed with movement, which is obviously a lot less risky than injections or surgery. And visits for 3 visits, that's an excellent episode of care for someone who's walking in certain shoes is quite limited. Patient number 2, 67-year-old female, intermittent right plantar pain for 6 weeks, also insidious, coming on for no apparent reason. Worse with weight bearing. This makes sense. Most patients who have foot problems are worse with weight bearing. The MRI in this case, not the ultrasound, was positive for 4x4 millimeter neuroma. Clinical tests, quick or orthopedic special tests, positive for the Mulder's click test, positive for the percussion test. So quite similar to the first person. Looking at the range of motion, the third toe flexion had a moderate loss with pain during movement, which is in contrast to end range pain. Extension of the toe had no loss, and lumbar range of motion had no loss. Now to the repeated movement testing. Repeated movement testing of lumbar spine had no effect. The clinician went to semi-loaded extension of the toe with some oscillations kind of rotating back and forth with the foot, and saw enough change in the signs and symptoms for the patient that became the home program. And what I'm typically looking for is something that the patient says is definitely improved. And if I had to give a percent, it's about 30%. But for example, if I had the patient do this semi-loaded toe extension 10, 20, 30 times, and then I had them do the provocative event, which is maybe a heel raise or moving the toe or going for a walk in the hallway, I ask the patient, is that worse, better, or about the same? And I say about the same because there is some leeway there. And I'm looking for the patient to say, oh, better. If I'm not convinced, if they're like, oh, it's a little bit better, I think, I say, give me a number, 5% better, 1% better, 30% better. And they say, oh yeah, it's about 5% better. To me, that's about the same. So that is not passing the test of absolutely, I can see some improvements. And I don't expect it to necessarily be 100% improved on day one. That's not really how these disorders work. But I want something clear enough for me to make it worth our while to test it over several days. So this patient went home with the semi-loaded extension of the toe with the oscillations. On visit 2, she was about 95% better, or almost nearly 100% better. And so they found that movement was still fruitful to do. She went home with that again on visit 2. And then they followed up with her at 6 months and 12 months by phone, and she said she was doing well. So again, small, short episode of care, diagnosis, in my terminology, of joint derangement, because moving the joint in a specific direction abolish signs and symptoms, or at least greatly reduce signs and symptoms, meeting the patient's goals, with a directional preference of loaded toe extension with oscillations. And oscillations is something I've never used before, but it's something that I'll keep in mind if I have patients that are presenting with signs and symptoms that might make me look at repeated toe extension in loaded or semi-loaded. So last patient, a little bit different this time, which is a nice change of pace. Still a female though, 54 years old, intermittent left foot pain, prolonged history, 8 years, worse with wearing heels, worse with walking, and worse with prolonged sitting. And this should start to kind of raise eyebrows, obviously in contrast to the first 2 patients, but pain with sitting when there's no weight bearing through the foot is different. And it's not something I really think of a lot when it comes to foot pathology. It's the same kind of like when someone says they have hip complaints, but they're fine with walking. It's not that common to hear that. Usually when there's weight through the joint of the extremity, that's when it's symptomatic, among other things, but definitely with weight bearing, such as going for a walk. So for this patient, also clinical imaging test was positive for neuroma, this time ultrasound like in the first case. The clinician looked at range of motion of both the second and third toes, flexion and extension of the toes, had minimal loss without pain, so in contrast to the first 2 patients. And then positive Mulder's click test, positive tender to palpation test, positive squeeze test. Now, lumbar extension range of motion testing, again, it's important for us to consider the spine for extremity symptoms. Lumbar extension, lumbar range of motion in all planes, I'm assuming, because it just said lumbar range of motion had min loss. So because we're hearing this in the verbal history that it's worse with sitting, because there's more of a pronounced range of motion loss in the lumbar spine, we're thinking there's a higher likelihood that this is spine. At least that's what I'm thinking. So the clinician looked at repeated movement testing as the third main part of the orthopedic evaluation, looked at lumbar extension with hip sag, so the patient's going up in prone, locking her elbows, breathing out, dropping her hips to get that self overpressure to end range lumbar extension in lying on her stomach. They did a few sets of that. He saw a positive improvement in signs and symptoms, so that became the homework. And in this case, the homework was not just perform this every couple hours, it was also attention to the position of the lumbar spine and sitting, so attention to posture and attention to minimizing tons of forward bending or flexion of the lumbar spine, which is the opposite direction of the therapy approach, or the the testing approach, which is lumbar extension. So they're 2 sides of the same coin, increasing the amount of extension in the person's life and temporarily decreasing the amount of flexion in the person's life, which might become permanent, but at least we're doing it temporarily to investigate. And if it's fruitful, it could be part of a lifetime prevention strategy or maintenance strategy. The patient came back on visit 2, reported about 100% improvement, so they did not change anything, and a follow-up phone call at 6 months and 12 months the patient also revealed she was doing well. So again, joint derangement diagnosis, directional preference of lumbar extension in prone. Now, we need more studies like this, but it does call into question what we're missing if we don't use Mackenzie's repeated movement testing as part of our orthopedic evaluation. That's why I use it, because we can find these patients. That's not to say that, of course, everyone has a joint derangement. That's not true. There are people with true structural problems with their nerves that need to be structurally fixed. But for a lot of people, and more evidence is emerging and is needed, of course, but for a lot of people, these problems are problems with mechanics. And if their joints are moving well, then the signs and symptoms abolish. And that's, again, what we call a joint derangement. So by adding repeated movement testing to the evaluation and continuing that testing at home, because repeated means repeated, it means not just doing it 10, 20, or 30 times, it means doing it a couple hundred times, we can figure out if indeed this patient can get better with relatively simple joint movements. The toe movements are very easy. It's kind of just going into toe extension in standing. It can be done very easily. It takes 5 minutes, maximum 10 minutes a day to do the sets required for the appropriate amount of testing. But we need to be able to find these people because their care is so much easier and faster than the other conventional types of care. So I don't want PTs just to use repeated movement testing. I want surgeons to use repeated movement testing. I want DOs and ortho MDs and podiatrists and any number of clinicians who see people with seemingly orthopedic complaints or non-seemingly orthopedic complaints to be able to use this as part of their diagnostic process so that we can better diagnose patients, because the better we do at diagnosing the problem, the better we can do at resolving the problems with the effective treatment.